So, welcome to the January membership meeting for the NAIPC. This is our Lunch and Learn meeting. Our speaker today is Latoya Galberth. Latoya is the CEO and founder of Galberth Health. She has nearly 10 years of experience as an occupational therapist servicing the geriatric community with a focus on dementia. She has so many accolades and titles, I couldn't actually list them all, but some that popped up where she was a clinical program lead for dementia management. She's a certified dementia practitioner. She's a GDS clinical specialist. And she received an award for outstanding patient outcomes. And I'm just telling you, if any of y'all are in healthcare, that's really amazing because it's all about outcomes. And to get an award for that, that's really good. That's really good. Latoya has served as an Alzheimer's caregiver support group facilitator with the Dementia Alliance of North Carolina. And she also volunteers with Meals on Wheels of Wake County. So I'm really not sure where she finds the time to spend with her husband and her new baby boy, but we are really glad that she found the time to spend with NAIPC and to be one of our valued members. So we greatly look forward to your presentation. Welcome, Latoya.
Why, thank you so much for that intro, Deb. I'm a little taken aback, but thank you so much. Now, I will go ahead and admit I'm not as tech savvy, so I'm going to attempt to do a screen share with you guys to start the presentation here. So once you guys can see it, if you can give me a thumbs up or a...
Yeah, we see it.
Yeah.
Perfect.
Looks good.
Awesome,
Yep.
Awesome. All right, so I'll go ahead and get started. Thank you so much to everyone joining the call. I know that we're a little over 3 weeks in, but Happy New Year. And for the sake of not just being another Zoom call, I do want to make this as engaging and as educational as possible. So again, I'm not very tech savvy, so I'm hoping Deb will manage the chat and let me know if there are questions that arise either during or after the presentation. So today I will be discussing the role of occupational therapy in dementia care. And I'm going to advance my slide. There we go. So let's start by defining the role of the occupational therapist. And this can be a bit of a gray area for many people. So I don't want to move forward with the assumption that everyone is familiar, because a lot of times due to my credentialing and expertise in dementia care, families and other professionals will commonly refer to me as the dementia care specialist or a certified dementia practitioner, which is awesome and highly speaks to the work that I do, but my ability to fill this role is due to my initial title and profession of occupational therapy. So the question I will pose to you is, what is occupational therapy? Is it A, the same as physical therapy? B, work and job recruitment? C, we rehab the upper body only? D, is the best profession in the world? Or E, we help patients develop, recover, and improve their skills and abilities for increased independence and function in daily tasks. So we will pretend as though the Jeopardy theme music has subsided. And if you chose D and E, you should thoroughly enjoy the remainder of this presentation. If you did not, you should still thoroughly enjoy the remainder of this presentation. So this next slide I like because it depicts one of my favorite quotes about OT's role, and it states that medicine adds days to life, occupational therapy adds life to days. And I actually shared this quote and image at the Transitions Guiding Lights Caregiver Conference a few months ago, and it further confirms just how truly miraculous the field of medicine is and speaks to essentially how we all aspire to longevity. So, developments in medicine have, without a doubt, increased our life expectancy. But what about the quality of that life? What are we living longer to accomplish? What are our highlights? What are our to do list? How are we adding life to our days? And what abilities and skills do we hope to have and to preserve when we're well into our 70s, 80s, and 90s? That's the beauty of OT. And I've had clients in the past who, when I originally asked these questions, would state that they're not interested in longevity or looking towards the future because of their current disabilities. So they typically say, well, I can no longer do the things that I enjoy, or I can't do things for myself anymore. So living longer doesn't excite me. And this is where we and why we as OTs intervene. So again, just to touch a little bit more on life expectancy, what does the data show? If I had a dollar for every senior, every family member, every individual that ever told me, Latoya, one word of advice, don't get old, I could potentially rival the current lottery jackpot. So we may not have much control over this. And the truth is, medicine is doing its part. In fact, the average age for the current life expectancy is 78.9, with an increase of 0.24% from 3 years ago. By 2050, the average age is expected to grow to 83.4. So, yes, we're living longer, but that doesn't necessarily mean that we're doing so diagnosis free, or should I say, dementia free. So, all of you guys are here through the National Aging in Place Council because you at least have an innate or developed interest in having our seniors, including those with dementia, age in place and to do so successfully. So, it's also important to understand the scope of our impact and projections, which, according to the World Health Organization, states that currently there are 50 million individuals diagnosed with some form of dementia. And by the year 2030, so in just short 9 years, that number will have grown to 82 million. So when we're talking about dementia, what are we talking about? And we're all familiar with it, be it personally or professionally, but to give you more of a concrete definition, dementia is the deterioration of our cognitive functions. So our memory, thinking, orientation, language, comprehension, and judgment. And with that in mind, it's even more important to note how we define cognition. And that is the primary determinant of a person's maximum level of functioning in everyday activity. I know that was a lot to digest, so I'm going to say it once more. Cognition is the primary determinant of a person's maximum level of functioning in everyday activity. So, not the only determinant, but the primary determinant. So, yes, we typically think of cognition in terms of memory, thinking, problem solving, etc. But our cognitive capacity decides our highest level of functioning. And as an OT, this is where I feel we're most effective. And this is what I mean. So you'll have to forgive me, as I felt the stock photos would not do this interpretation justice. But I did, however, receive permission from my families and clients. So I thought this would be perfect. And I'll definitely revisit these images with explanations later. But I just wanted to reiterate that in the world of medicine, there is nothing as dynamic and as complex as dementia and its progression. And when you think back to the descriptor of OT, our holistic approach and ability to address the physical, cognitive, and environmental barriers, it makes a lot of sense how well equipped we are for this line of work and for this particular disease. And for me personally, if you give me an individual with a functional decline, be it physically or cognitively, I'm going to aim to give you back these same smiling faces with increased functional independence. So now I just wanted to take a moment to address a few of the hot ticket items as it relates to our role in dementia care. So, no surprise here. ADLs, activities of daily living. So this is inclusive of our bathing, our dressing, our grooming, self-feeding, toileting. So I wanted to scale back to the bathing component. So what about the patient or loved one that hasn't showered in 6 months? Or 3 months, or 4 months, or 5 months. And they also say, well, I can't take a bath here. This is not my home, and I'm waiting for my mother to pick me up. I'm sure we've all met someone along these lines within our profession. And I have actually had the pleasure of working with a family whose spouse had essentially all but given up. He had definitely resorted to his support group and different seminars, which was very important in just helping him understand dementia and its progression and its correlation with ADL care, or in this case, lack thereof. But he was having a hard time implementing some of those strategies and some of those techniques. So OT was summoned again to address some of that problem solving as well as interventions in the context of the home, which is ideal. And I'm always providing families with different resources and supports and services, which is all great information, but it's not always individualized, again, contingent on the dynamics of that family and what's available in the home. So being able, again, to go in and do some of that one-on-one and personal care as it relates to ADLs, again, in the context of the home, is always, always ideal. And then sometimes it helps just having a healthcare professional appear on the scene, a second set of eyes, a different pair of hands, if you will, that's done this over a million times, so that you as the caregiver don't have to necessarily reinvent the wheel. And then sometimes it's the smallest adjustment or tweak or oversight that saves you time and decreases those what we call bath time blues. And our clients with dementia, they do typically respond better. And when I say respond better, I do mean comply with those who appear to be an authoritative figure. So for me personally, when it comes to bathing, dressing, grooming, and I'm doing an assessment, I'll go in and say, Dr. Sunflower sent me to do a little bit of an assessment to see how well you're transferring in and out of your shower. I want to make sure that it's easy for you, that you're nice and comfortable. I know you will probably never enjoy it, but I want to help you as much as I possibly can. And again, I do it all and I say it all with a smile, which is a lot better than some of the approaches of, you know what, you don't smell too well. It's time for you to take a bath. And not to toot my own horn, but I do have a 99% success rate in getting my folks to shower at some point in their plan of care. And then also, we have to consider where that individual is as it relates to their dementia. So, again, they could have done this particular ADL task for years and years, but now they have regressed to a stage of their dementia in which this is completely novel and completely uncomfortable. So, is it absurd to think that they actually wouldn't like to shower? And as OTs, we're asking, what is our end goal? What is the end goal of the family or that particular senior? Is it to shower? Is it to be clean? And then we work with the family to help decide on an ideal frequency, again, to minimize risk of infections such as UTIs. And then moving on to some of the physical implications. So let's say our loved one with dementia is now non-weight bearing. She succumbed to a fall and again has also developed a fracture in her foot, for instance. But she doesn't know that she's non-weight bearing until she stands up and she's in extreme pain. So now we start to think whether or not the utilization of visual aids for sequencing and compliance would be beneficial for this individual. And then also being available as OTs to address some of those physical limitations, because again, dementia does affect our physical abilities as well. So we have to address those barriers accordingly and acknowledge its place in traditional rehab when addressing things such as balance and gait. For example, someone with vascular dementia may experience weakness on one side of the body, affecting their balance, their ability to transfer, their walking. And then some of us may know that one of the hallmarks of Lewy body dementia is the shuffled gait, as well as the muscle rigidity and poor posture. And studies show that early detection and early intervention will not only reduce that rapid progression in their dementia, but also reduce the rapid decline as it relates to their functional independence. So again, we're OTs in dementia care. So are we just going to hand our client an exercise handout and say, let's do these leg lifts all day? Absolutely not. Our focus is on implementing holistic and skilled interventions that, again, will increase that follow through. And I've had clients who've worked with other therapists and agencies in the past who sometimes would become a little frustrated because their loved one just couldn't get it, that their loved one just couldn't count up to those 20 reps. And there was oftentimes a little bit more of that disconnect. So I say that to say that we all have our places in the field, but it's definitely pertinent that I highlight the importance of experience, knowledge, and compassion when it comes to bridging that gap between rehab and dementia care. And as we know with dementia, there isn't a one size fits all. And a lot of what we do as OTs in this field is to find ways to effectively create new habits while amending some of the old ones. And then as OTs, recognizing the weight that we carry in these circumstances and the importance of buy-in for both the caregiver and our client. So we're assessing everything from rapport, approaches, the environment, physical limitations, their stage in dementia, and again, ways we can improve function to get them closer to their goals. And this oftentimes will include a task analysis, again, in which we ask, what is our end goal? And then also figuring out the best starting point, again, with these factors in mind. And that leads to the importance of training. I've worked alongside staff who enjoy taking the old rip the band-aid off approach when that's the very last thing you should do for our clients with dementia, especially in the area of ADL care. So again, our task analysis, be it formal or informal, is very helpful in that regard. And then just talking briefly about the home management piece, as there are quite a few seniors with early dementia, early stage dementia, or a mild cognitive impairment that are living at home alone with supports in place that are a bit more sporadic, but still needing some assistance with things like medication management. And sometimes it boils down again to the OT's ability to go into the home, assess that breakdown, and then collaborate with those in the community on probable fixes. I actually consulted with a pharmacist with one of my clients before to come up with a strategy on how to best prescribe and deliver their medication because he was simply not adhering to the pill pack and missing quite a few doses, which we know can cause greater complications down the road. He was even prescribed medicine for memory loss, which he could not remember to take. Oh, the irony, right? So again, it doesn't mean that there has to be someone that physically goes in every 3 to 4 hours to make sure that they're taking that medication. But again, considering alternatives based on cognitive performance, again, to maximize that compliance, should we consider visual aids or auditory alarms or home automation systems, or again, just a different strategy altogether? So I proposed, instead of prescribing the monthly pill pack, that we scale back to weekly and biweekly, because again, we still want to allow that level of autonomy for as long as possible, with also keeping safety at the forefront. And behavior management. So we know behavior is the common marker of dementia, and probably one of the biggest, if not the biggest, stressor for our caregivers. As OTs, we work really hard at figuring out how to address and increase safety and compliance for our no clients. And I actually like this picture because a lot of the times the problems kind of lies within us. We again have the ability to change. We are the ones without those cognitive impairments. So it is imperative that we do some of those modifications. So again, our no clients, modifying our approach, working in communities alongside staff and families to mitigate the occurrence of those behaviors and offering solutions. Should there be a room change? Should we opt for eating in less noisy dining rooms? Do they have severely arthritic knees and it hurts for them to stand? So that's why they become combative during transfers. Speaking of behaviors, I had a client who was absolutely not interested in therapy. Very sweet Korean lady who definitely struggled with parts of English just by nature and also suffered from dementia. And so I'm thinking, oh, this is going to be fun. And I mean that with absolutely no sarcasm because I am the moth to the flame when it comes to behaviors. I actually love taking on these clients. But in her case, I learned different phrases and songs and Korean customs and used them as motivators in our session. Her walking distance improved dramatically when we would play a certain Korean song, and she would become less anxious, less upset, just long enough to make fun of my Korean accent, but it did distract her from some of those negative behaviors and encourage participation in tasks that were more meaningful and beneficial for her recovery. And then looking at engagement. So know that we define behaviors as the discrepancy between one's abilities and the perception of what they can do. So again, behavior is defined as one's discrepancy between their abilities, be it physical or cognitive, and perception of what they can do. So the OT will essentially decide what is well suited for this individual, what are their triggers, and then our ability to build rapport and trust and discover those aha moments is so important. And our company is fortunate in that all of our clinicians are certified dementia practitioners. So we work extremely well with our patients to unveil some of their deep rooted fears or inabilities when they can't communicate that to us. So we're able to do the detective work to lessen the load for our caregivers who are busy right now juggling every other ball imaginable. And then we're able to create and provide tasks that are engaging and cognitively appropriate that can also be used for redirection for, again, someone with those behaviors. And when these behaviors, physical limitations, and their impaired safety awareness leads to falls, we're able to, again, bring in our entire team to address balance, coordination, and, again, appropriate use of assistive devices because safety is so important. And we know that if that person with behaviors is adamant about doing something, it would be in our best interest to create avenues and alternatives to lessen that frequency. And then our goal is to ensure caregiver success. Again, keeping in mind that with behavior that no one can perform higher than their cognitive ability. So it's almost synonymous with the saying of when you know better, you do better. So we have to ask ourselves, are we forcing this particular individual to do or know more than what their dementia allows? Because this can be very frustrating. And again, the perfect recipe for those behaviors. So again, we're able to know where they are in their stage of dementia. Again, having a clinician or a practitioner help determine that and to safely and effectively manage those behaviors as a consequence. So now I want it to kind of shift focus to the home. So our goal is to have that individual age in place for as long as possible, but we often do see referrals for that reacclimation from one environment to the next. So yes, there are physical changes that may have caused this progression that may accompany that transition, but we also have to consider the cognitive, the social, and the behavioral changes that may accompany that as well. So now we're looking at rebranding and orientation as it relates to their home. As OTs, we're asking about those diagnoses of memory loss or mild cognitive impairment and how it's associated with disorientation. And again, problem solving. Do we need to work on including visual aids or again, use of home automated systems? We can also look at means of scheduling and organization, particularly in those with early stage dementia. And then also opportunities for simplification due to clutter, because we all know of someone who prides themselves on being the hoarder and the hider. And we also know that clutter can equate to falls. And then also asking the question about their environment as to whether or not it's over or understimulating. The OT can come in and assess and determine those thresholds for those sensory needs. Is there too much or too little auditory input, too much or too little tactile input, too much or too little visual input? Again, very important questions to ask when assessing that environment. And then using our skill sets to ensure that their new or old environment now fits their new needs. So, are we looking to order a motorized scooter to better fit their environmental or mobility needs? And if so, do they know how to operate this from a cognitive standpoint, or do we need to consider other options? Will they benefit from a lift recliner if they're having difficulty transferring? And if so, how can I modify the remote feature to make it easier for them to comprehend and utilize? And we also know that those with dementia have a greater risk for falls. This risk actually doubles for those with a cognitive impairment. So we have to ask what has potentially become a distraction in the home or unnecessary. Throw rugs. Are pets becoming more of a hazard now? Should we consider designated areas in the home to keep these animals? And then depth perception, especially when you're considering moving from one home or environment to the next. Possibly considering downsizing to a one level home for your particular loved one with dementia. I did a presentation with Deb, I think it may have been over a year ago now, where I polled the attendees and asked where they would like to age in place. So it was no surprise there. The majority of them said in their home. And a study also reveals that 83% of retirees plan to live at home, but only 40% can actually do so safely and functionally. So, again, this is where we can come in, again, with the assistance of you guys and others in the community to minimize that discrepancy, especially, again, for our clients with dementia. And then caregiver education. So, considering what lies ahead and alleviating that burden by teaching and empowering our caregivers, because we are able to view things from the lens of both our patients and our families. So, also note that there's no one stage in which we can enter because there's true value that can be added in so many ways depending on what interventions have been implemented or never considered to begin with. And I always say being proactive will get you a lot further with a lot less headaches. And then on the opposite end of that spectrum is educating everyone on what's called excess disability. So we're all guilty at some point, I think. And overdoing. So, doing for that particular individual with dementia instead of with. So, we potentially have the assumption that they can't do anything for themselves. So, you and I on this call, we are all of sound mind and we're able to communicate that we're able to do or not do certain things with supports in place. But again, our seniors with dementia cannot. So, those guided interventions we can implement to ensure that they reach their maximum potential, again, for that decreased caregiver burden. And then building the village, working with those like you. We do a lot of work with home care agencies and care managers, and just knowing when to make that call if we see a noted decline in function that we feel may spill over into other areas of our session, especially if they're living alone. And again, this is a process, and we all know the prognosis as it relates to dementia. So there will be need for some of those additional external supports at some point. And then our ability to reintervene at each stage, particularly when there's a noted decline, to review the interventions that were previously in place and decide if it's time to incorporate new ones. So all it takes is one fall, one UTI to send that loved one's dementia spiraling into the next stage. So now we can pivot and work on regaining some of those functional abilities in a modified manner, of course, or preventative measures to again reduce that reoccurrence. So, OT, dementia care, a pandemic, woo! 2020 needs no introduction. It definitely revealed a lot. So, For our OTs, the bigger question was, how do we address function and increase living during a pandemic? And what we found was that families would come to us basically trying to figure out new living arrangements. Mom is no longer in assisted living, or dad is no longer attending the adult daycare center. And we are not, by any stretch of the imagination, home care, but we do offer respite by way of skilled intervention. We're thinking long term, and we're thinking of ways to keep things cost effective for the caregiver, while also allowing them to spend quality time with their loved one. A lot of families didn't have that privilege during the pandemic, and we're just trying to help them keep their heads above water. And we've done everything from figuring out cognitively appropriate activities for engagement to having them figure out how to get mom or dad in the house, because now their mobility has declined because they haven't gone out for the past 6 to 9 months. And I'm actually working with a family currently who transitioned mom home from an independent living facility into a multi-level home, where there's no downstairs master, and mom has severely arthritic knees, making it difficult for her to go up and downstairs. So their question has been, how will we get her to her doctor visits? How will we get her to her grooming appointments? How will we get her out to take the vaccination when that's available to her? So this all looks very different now. So what new skill sets are needed, or preparation measures taken to ensure not only a safe but successful trips for that particular loved one? And I even found myself a little over a month ago working on car transfers so that my client can, when needed, transport himself to a COVID testing site. So, again, these are very different times, but the needs couldn't be greater. So, we want to make sure that we're addressing everything across the spectrum. And then sometimes we're helping families and seniors figure out the best means of communication, while also considering their anxiety levels as it relates to the pandemic. Training on options for virtual calls or FaceTime calls with loved ones, while also working on cognitive retraining at the same time. And then just that continued focus on quality of living, because again, nothing is off or has been off the table as it relates to the pandemic. So again, what is the role of OT in dementia care? It's addressing the physical and cognitive limitations and implementing interventions so that our clients can both prepare and participate in the holidays, as you see in that picture there. Engagement, standing balance, strength, task simplification, and addressing behaviors, as well as tasks that aren't trivial but purposeful and will improve standing tolerance and use of the walker, as you see with the car wash and the gentleman there, working on transferring to a piano bench and playing music for other residents in a long-term care facility, and restoring a bit of normalcy for our caregivers and educating them on opportunities for community engagement, again, in the future when that's a possibility again. Because we know that currently there are caregivers in the home, but we also have to consider options for families who will eventually want to have their loved ones go out on those appointments or events or outings. We want to make sure that they do have the physical and the cognitive supports in place when doing so. So, yes, I am being very optimistic, because I do know and understand that this pandemic won't last forever. So, it's important that we make sure that our seniors and their skill sets and our abilities aren't lost forever, particularly during this time. So, last picture, this is a picture of my absolute favorite patient, all pro bono work. Love her, love her, love her. This is actually a photo of myself along with my late grandmother, who was diagnosed with Alzheimer's several years ago. I was a huge advocate and OT for my grandmother, and I like to think that my involvement, even down to educating my family, played a really huge role in that. I was the OT there for her initial diagnosis, getting very creative and implementing strategies and approaches. when we had to take away those car keys when she was no longer safe to drive, revamping the kitchen area for safety, working on orientation, introducing the walker early enough in her care so that she wouldn't forget it and it would become a fall hazard, working on balance, strategies for sundowning, identifying triggers for a behavior, transitioning to an assisted living facility, again, to ensure as much consistency as possible, doing caregiver training, modifying activities for continued engagement, making skilled adjustments due to her decline in vision and balance, and then consulting with other disciplines such as speech therapy when we needed to downgrade her diet. Working on transfer training, ordering adaptive equipment for those transfers, addressing toileting and showering to ensure independence and safety. And when her Alzheimer's progressed, affecting joint mobility, working on contracture management and passive range of motion so that she could wait there and make it easier for staff to help with her transfers, modifying approaches to self-feeding when she would become reluctant to eat, all until she was admitted into a skilled facility and appropriately referred to hospice. And even then, I would still do consultations with the nurse there because I did have essentially all of the ins and outs. So all of this took place pretty much over a time span of about 8 years. So that gives you an idea of the maintenance and again how important we are in the role of limiting that quicket or that rapid succession into the next stage of dementia. And this ongoing involvement in skilled care is really and truly what I recommend and encourage. I get so many calls and emails starting with, Latoya, we need you back. And as it pertains to OT, I never feel that it's too early or too late to receive those supports as it relates to that person's dementia journey. So I say all of that to say there will always be a place, always, for occupational therapy in dementia care. So, if I haven't convinced you of a career change to OT, I simply ask that you consider those that you work with, be it loved ones, those in senior communities, your neighborhood, your church family, again, that they consider the great benefit of having an occupational therapist as a part of their care plan, while you obviously help to continue to provide support and services and resources to our families and caregivers in need. Our therapists truly want to ensure that there isn't that excess disability and that we, along with you guys, can be a great contributor. And again, adding life to days, as I alluded to before, for increased quality living. So, I will wrap up and make sure that you guys, I think you can see it okay, have access to myself well after the presentation. So there is my email address, and feel free to visit our website as well, or give me a call at the number listed on this slide. So thank you guys again. I hope that information was beneficial and that I didn't bore anyone. And thank you, Deb.